So I decided to do my lecture on CAR T cell therapy. Thankfully, this was on the approved list in the syllabus. Dr. Blair had shown a video of it the other day, and I'd never heard of it before. He showed a video in class the other day depicting what it was and how it worked, and it was pretty interesting. I'm very much interested in the field of oncology. It's one of the things that does attract me to veterinary medicine as well. There's a lot of comparative anatomy and comparative medicine that comes out of the relationship between humans and dogs, believe it or not. And there's been a lot of advances in the oncology field from this type of comparative anatomy. In fact, one of the first bone marrow transplants that was ever done in the field of oncology was done at Colorado State University in their teaching hospital for their vet school there. And, just think about comparative anatomy. What's done in a dog could also be done in a human. What works, what doesn't work, kind of, you can get some good information to build on from that. So that's just a little bit of background of why I picked this lecture to do. So what is CAR T-cell therapy? Let's talk about T-cells first. A T-cell is a lymphocyte that is developed in the thymus glands of an individual, and it plays a central role in the immune response of that individual. A CAR T-cell is a T-cell that has been genetically modified. It's been infused with chimeric antigen receptors. Those receptors are what actually will bind to cancer cells and kill them. And that's also how we get the name CAR T-cell, chimeric antigen receptor. It all fits nicely there. There are different ways to modify these T cells. There's a viral or a non-viral transfer method, DNA-based transpond, CRISPR, Cas9 technology. And then there's also a way of direct mRNA electroporation. That's in vitro transcribed mRNA through electroporation. So this is just an overall look at the therapeutic process. Before the patient actually gets to begin this process, they have to be vetted and qualified. We'll talk about that more in a different slide, but there is a series of hoops and hurdles that they have to go through to get to this process. It's also a very expensive process, so the patient does need to make sure that they know everything that they need to know going into this process. So the patient comes into the clinic and their blood is drawn. They're put on a machine that will separate their T cells from their white blood cells. The T cells are kept and the rest of the blood is put back into the body. This process takes about an hour, hour and a half to do, depending on the patient. These T cells that have been separated from the blood are then sent to a lab, and they are put through an attenuation process. There's a virus, an inactive version of a virus is introduced to the T cell, and then the virus will interject its genes into that T cell. The T cell will then become modified and grow these special receptor proteins, which remember are the chimeric antigen receptor, and those are what will actually bind to the cancer cells. And these T cells are replicated in the millions. They want to give the patient the best chance of attacking all these cancer cells. So they want to outweigh the enemy, pretty much. So all these millions of T cells are sent back to the hospital. And when the patient is ready to come back and be reinfused with their modified T cells, they are put through a short course of chemotherapy. Now what that's going to do, it's going to weaken the patient's immune system slightly so that the immune system will rely on the new T cells that are coming in, the genetically modified T cells that will attach to the cancer cells. So the receptors will be attracted to the cancer cells. They'll recognize that it is the cancer cell, and they will attack. They won't attack one at a time. They'll just kind of overwhelm the cancer cells, attack at whatever spot that they can get a hold of, and then they will kill the cancer cell, which is ultimately the goal. Kill the cancer cells, and you will get rid of the cancer that's in the patient's body. So that's just an overall process of what is actually CAR T-cell therapy is. It was approved by the FDA in 2017. There are two CAR T-cell treatments that are available, and I'm going to hope to pronounce these words right. There's Chimera. Those are used on pediatric and young adult patients, generally at the age of 25 years old or younger. This therapy is used mainly for non-Hodgkin's lymphoma. And then there's Yescarta. This is for large B cells for non-Hodgkin's lymphoma. This does not have an age limit on Yescarta. So the qualifications I was talking about while we were looking at the overall process, the patients have had to have tried two other standard treatments of cancer, and they have either had to relapse on these treatments or have had no response to these treatments. So they've had to already try two other types of treatment, and it have not worked before they can begin to try CAR T-cell therapy. The FDA has approved other clinical trials. These are not available for therapy yet, but they include clinical trials to fight leukemia, lymphoma, multiple myeloma as well. There are some side effects that were observed with the CAR T-cell therapy. One of the most dangerous ones that doctors are looking for is the cytokine release syndrome. Cytokine is a chemical messenger that tells your T cells, or organizes the attack on the immune system. So cytokine tells the T cells where to go to fight anything that's in the body that's foreign. If too much cytokine is released into the body, you'll observe high fevers, low blood pressure, difficulty breathing, and organ failure. There have been some temporary neurological responses associated with the therapy. Confusion, slurred speech, seizures have been noticed, and again, these are temporary neurological responses. There's also been a low blood count, low red blood count, and white blood count. Chills and shaking, nausea, vomiting, and diarrhea have also been associated with this therapy. So the results, how good does it work? There's you have to weigh the good with the bad with this type of therapy. For individuals with acute lymphatic leukemia, in their end-stage patients, 92% have had full recovery that were involved in the clinical trials. Now, that sounds good, and it is a good thing, 110%, but that is just one specific type of cancer that it has been observed to have full recovery in a large amount of the patients. They have had the most success in the hematological cancers. They have not had much success with solid tumorous growths. This is due to undefined therapeutic barriers, and that is what the clinical trials are hopefully going to start giving answers to. So that's kind of CAR T-cell therapy in a nutshell. Thank you guys for listening.